Assalamu alaikum, I'm Dr. Abdulaziz Yusuf of the Welcome to Pediatric Case Review. Today we'll review diagnosis and treatment of bronchial asthma. We have 4 cases. Case number 1. A 3-year-old child presented with fever, rhinorrhea, and shortness of breath. History revealed recurrent attacks of cough, shortness of breath, after exposure to dust, smoke, and sometimes at night during sleep. Examination showed temperature of 38, respiratory rate of 50, mild retractions, and diffuse expiratory wheezes. So what is the most likely diagnosis here? The most likely diagnosis here is bronchial asthma. We have triggers like upper respiratory infection. Other triggers may be present as passive smoking, exercise, cold air, and aero-allergen exposure like dust and etc. Recurrent attacks. Asthma usually presents with recurrent attacks of shortness of breath and cough. Dyspnea and expiratory wheeze are usually present in asthma. Case number 2. A 6-year-old child, known case bronchial asthma, presented with cough, shortness of breath after exposure to dust. He can speak complete sentences and feeding well. Respiratory rate 25, heart rate 100 beats per minute, saturation 93, and peak expiratory flow 60% of predicted. So what is the most likely presentation here? The most likely presentation is mild to moderate asthma, as vital signs are normal like respiratory rate and heart rate. Only saturation decrease about 1, and the patient has cough and there is trigger exposure to dust. Next is, what is the best next step to treat mild bronchial asthma? Mild bronchial asthma attack should be treated only with salbutamol meter dose inhaler 2 to 10 puffs via large volume spacer. Also, like this case, if saturation is below 94%, we can give oxygen to the patient for hypoxia. If patient improved, no further treatment or admission required, you can discharge the patient once daily oral prednisolone for 3 to 5 days to control the acute attack. Also review long-term control and modify accordingly. Case number 3. A 7-year-old child, known case bronchial asthma, presented with cough and shortness of breath after exposure to fuels. He is too breathless to talk. Respiratory rate 42 and heart rate 145 and saturation 90%. Peak expiratory flow is 45%. A chest auscultation, severe wheezes, and also retraction. What is the most likely presentation? This is a severe attack of asthma. As we can see here, respiratory rate more than 30 in a 7-year-old child, and heart rate more than 125, and saturation less than 94%. Also peak expiratory flow rate less than 50%. What is the best next step for management? First, correct hypoxia by oxygen via mask or nasal cannula according to response of the patient. Then we can give bronchodilators. We have 2 bronchodilators. Salbutamol meter dose inhaler, 10 puffs via large volume spacer, or we can give salbutamol nebulized driven by 6 to 8 liters per minute oxygen. Also, we can give nebulized ipratropium of no improvement after salbutamol, MDI, or nebulizer. We will start oral prednisolone and continue after that, or if we can't give oral prednisolone, we can give IV hydrocortisone. If the patient improved, discharge criteria met, we can discharge the patient once daily oral prednisolone for 3 to 5 days and review long-term control for that patient. Case number 4. A 4-year-old child, known case bronchial asthma, presented with cough, shortness of breath after exposure to fumes. He looks pale, with poor expiratory effort. Saturation 85% room air. Chest, silent chest. We cannot hear breath sound. What is the most likely diagnosis or presentation here? This is a life-threatening asthma. What is the best next step for that patient? First, inform the on-call consultant and PICO to take support. Second, you can give oxygen via mask or nasal cannula. Second, you can give oxygen via mask or nasal cannula. Bronchodilators, continuous salbutamol nebulized driven by 6 to 8 liters per minute oxygen, and also nebulized ipratropium bromide. Hydrocortisone slow IV should be given for that patient, not oral. And also, if signs of shock, sodium chloride 20 milliliter per kg, normal saline IV bolus should be given. Notice here in the presentation, we didn't mention peak expiratory flow because this is a 4-year-old child, and peak expiratory flow should be used 5 years and above. For this child, if no improvement after the above treatment, consider salbutamol IV, magnesium sulfate IV, and also take blood gases and do chest X-ray. As a final conclusion for today's cases, remember the following. Asthma is a clinical diagnosis. Always search for asthma triggers. Asthma classified according to presentation into mild to moderate, severe, and life-threatening. Assessment of asthma mainly include general condition, conscious level, and the ability to talk or eat. Also vital signs and saturation, and chest auscultation and use of accessory muscles. Also peak expiratory flow rate in children 5 years and above. Main treatment of acute asthma attack include oxygen as needed, bronchodilators, and steroids, either prednisolone or hydrocortisone. Avoiding asthma triggers is the best prevention for asthmatic attack. Also, you can subscribe to our channel and activate the bell for the following cases. So if you find this video helpful, please like and share to your colleagues. Thank you for watching.